Ladies and gentlemen, if you want to get out your phones and take pictures over the course of today, the hashtag is hashtag Healthtech O2O. There's a Twitter account. There's a Facebook account. There's what they call a show page on LinkedIn. So if you want to get on those and keep up with us today and forever, please feel free to do so. I'd like to introduce our next speaker. This gentleman has an absolutely ginormous responsibility. There are a little bit over 7 million people in Hong Kong, and the hospital authority take care of pretty much almost every single one of them. Almost, I believe, over 90% of outpatient, inpatient. The hospital authority is there for the people of Hong Kong, and of course, that means a lot of data. This gentleman started his early days in Calgary, where the Cowboys come from. He got on his horse, and he rode it to Hong Kong. He arrived in the city, and he has taken his love for technology and helped to build up the hospital authority's technology systems over many, many years. He has risen to the position of Chief Medical Informatics Officer with the hospital authority. He is the consultant to the government on e-health. He has got two huge projects right now, one of which is working with doctors and clinicians to manage data and collect that under their new CMS. And he is also working on health records for individuals. He's got the people of Hong Kong on his mind every day, but we lend him out, and he travels around the world to speak about informatics in the health sector. Ladies and gentlemen, if you could please welcome to the stage the CMIO of the Hospital Authority of Hong Kong, Dr. Cheung. Thank you very much, Dr. Cheung, for joining us.
Thank you. Cheers. Okay, this is working. Andrew, could you give me a five-minute warning? Oh, I do? Oh, fantastic. All right. Okay. So I'm actually, I am a medical doctor by training, but I gave that up years ago to become an IT person. So I'm actually now apart from the CMIO, which is the medical informatics side, I'm also the head of the whole IT at the hospital authority. And Dr. Cheung mentioned I also do help the Bureau with a lot of work, especially developing the EHR. So we are, this is Start Me Up. So I presume most of you are from the startup ecosystem, rather on the tech side or the finance side. I am from the opposite of a startup. The hospital authority is one of the biggest organizations in Hong Kong. It's one of the biggest healthcare organizations in the entire world, actually, as a single entity. And I know in the startup world, there's a lot of talk about disruption. That's what you want to do, disrupt industries, make revolutionary changes. We can't afford to do that. We are very much on this side, more incremental change. Disrupting the hospital authority means everybody in Hong Kong doesn't have, care. So but we still find a way to do sort of innovation we need to do without disrupting things. And I want to talk I'm going to share with you a little bit about how that works and maybe how that will allow us to work together, the two different worlds, maybe working together to improve things in Hong Kong. So, and I do understand this focus on disruptive change. This is a quote from Steve Jobs, a guy that I do admire greatly. Well, I did admire when he was around. But even he said, he has a great respect for incremental improvement, but the revolutionary stuff is much more fun, much more exciting. And I respect that. But unfortunately, I'm not in a position to disrupt things. I can do things only incrementally. And this sort of shows that. I've been to the hospital authority. I actually joined, not at the very beginning, I joined in '93. And since then, so that's 25 years now, 25 years ago. And what I've been doing at the hospital authority for 25 years is I've been building the same system, the exact same system for 25 years. Basically, that's the CMS here. It's called the CMS, the Clinical Management System. And the idea there is that we would convert the hospital authority into a digital place from an entirely manual situation. It was a greenfield situation. No, everything was on paper. And over the years, we developed in-house all these systems to get us to where we are today. And today, we're at CMS. We're at stage 4. We're starting phase 4 now, the fourth generation of CMS. Dr. Cheung mentioned the EHR, which is the government system, which was launched last year, and now we're starting stage 2, and a tremendous amount of work by a very large team. I probably have the largest development team in Hong Kong as well. Definitely not a startup, but a lot of work over a lot of years. So this has been a 20-plus year project for me. And when you run a program that long, you have to, it's not a project. It's a philosophy. It's a culture. So just want to share with you a little bit about sort of the thinking behind this 25 years of work. And I have to apologize. These slides are supposed to move, but because I have such a nice screen here today, the formats are different, and so it's more static. But never mind. So the idea is that we're focusing on the record. You would say the data, right? But for us, clinically, it's an electronic patient record. That's how patients are treated, and that's how their data is all stored in a structured, comprehensive record that is accessible by clinicians wherever they need to see it. Okay, so Hong Kong it was unique for many years as the only place in the world where you could look at a patient's entire electronic record over a whole city. That really, and there's still very few places you could do that. When I was in the US in the 2000s, now the US, of course, has been doing this sort of stuff for longer than anybody else in the world. And they spent the most money, they have the most advanced tech. But I was in Boston, which is the health tech center of the world, perhaps. And there's two famous hospitals on the other side of a road. If you went to one hospital here, and then you had to see the next hospital here, your record would not be transferable. You'd be carrying a stack of paper across the road. Any Americans here? This might resonate with you. In Hong Kong, at the same time, we already had a system where the entire record was electronically shared across the whole place. So we focused on that. Secondly, the record itself is just data for people to look at. How can we support the actual process of care? So the doctors aren't repeatedly entering stuff and all that. And can it help people do the right thing the first time? So that's the process of care. And lastly, there's a lot of specific work that we did to support specific incremental quality improvements over the whole of the hospital authority. Now, one of the advantages of having a system like this is that in a place even as large as the hospital authority, if we have something which we want to improve some process in one hospital, if I implement it through the system, that process gets automated across the whole place. And we're able to roll out things way faster because of the system being in place. And of course, once you put something in place, if it's in the system, it stays there forever, keeps on running. People forget, people lose focus, but the computer never does. All right, here's what we were starting with in 1990, right? The paper record. So I love showing this because it's just ridiculous. This is what we used to treat people based on, handwritten scribbles like that. And this is not a bad example. This is actually considered good doctor's handwriting, okay? And this is how they were stored, all right? Masses and masses of paper. Now, I'm not going to tell you that we don't have any of this anymore. We haven't gone paperless in the hospital authority. It's a very difficult job. But this was what it was entirely based upon, is people going in these stacks of files and finding the right pile, hopefully, and giving it to the doctor. What we have today is we have it all on electronic form. Not all of it, I'm sorry, but all the important stuff is already electronic. So you can look at all the various aspects of a patient, no matter where they receive their care in Hong Kong. And this now, with the EHR, extends out to the private sector as well. So it's not just the hospital authority, it's also the private sector and the private GPs and all the other people involved in the healthcare world can see your entire record. And I mentioned processes now. A hospital is a tremendously complicated place. And so there's a lot of things happening in hospital. And now basically the CMS system applies across the board, basically. Everything they do is recorded or transacted through the system. Right, it's a huge system. We have 3 petabytes. That's a slightly misleading figure. It's 3 petabytes of storage under management, but it's not actual 3 petabytes of actual data, but still huge. And look at some of the numbers, billions of results. The other thing we have to do, of course, is this has to be very responsive because doctors aren't going to wait for a computer. And the uptime, it's 7x24 business. They would prefer 100% uptime. That's rather difficult, but we do 99.98 thereabouts. So it's a very high volume system as well. And what it's a massive system. We liken it to a 100-story building. It's multiple layers in this huge stack over, well, tens of thousands of devices, hundreds of applications, hundreds of servers, etc. So this is what's running the hospital authority in Hong Kong today. Right. Now, we started in 1990 when there was hardly any computers. Well, actually, no computers in the wards in Hong Kong. And then it took us 25 years to get to where we are today. Just for comparison, just to give you some reference, this is from the US, again, a place which has spent by far the most money in this stuff over the years. Now, in 2006, there's an organization called HIMSS, which looks at the adoption of electronic medical record systems in the world. And they do this survey every year to see how the hospitals are progressing. And they do a sort of a accreditation sort of thing where they look at how advanced you are. And basically, stage 4 is when doctors actually start using the computer to actually affect their care. If you don't get to stage 4, you're not affecting the care that's being provided. All you're doing is documenting it electronically. This is where you actually make change. So, in 2006, 2% of hospitals in the US, 2%, had reached a stage where doctors actually having their care advised upon by a computer system. So the system is actually materially affecting care, 2%. 6 years later, with massive amounts of investment, is up to what? Added it all up above stage 4, 25%. Something like that. Very slow progress. It's actually incredibly difficult. What has happened, actually, to be fair to the US, in the intervening 6 years, there's been a massive amount of money. We're talking about billions and billions pumped into the system, and that has dramatically increased the uptake. So it can be done. But of course, in Hong Kong, 2006, we were 100%. People were using the computer for almost everything already. All right. I just want to share this with you. There's a video that was produced years ago by EDS, and it was an ad, but they were talking about building an airplane while it's flying. That's actually a very entertaining video. If you Google it, YouTube it, you'll find it. Building airplanes in the sky. And the idea here is that they're talking about while the jumbo's in flight, they're still building it. And you can see there's a funny bit where the passengers are sitting there drinking coffee while the wind's blowing through their hair on this plane. Right. And the reason I bring this up is because that's more or less exactly what we're doing. Because we're running, the largest health site in Hong Kong by far, and we're modifying it while we're running. We can't stop the hospitals and say, hey, everybody stop for a while, we're going to upgrade the system. You can't do that, right? It's all constantly in flight. So I quite like that video. And what I'm going to do now is share with you some examples of how we do stuff in that environment. Right, so here's my case study. So it's inpatient medications. Now, inpatient medications are one of the most complex areas in healthcare. Just the processes involved. And that means when you're lying in your hospital bed, the doctors are prescribing drugs for you, the pharmacists are looking at the drugs and packing them for you, then the nurses are administering it. And it's all done, it all used to be done on these pieces of paper, these medication charts. And once again, you get to this lovely handwriting problem and people scribbling on it and all that sort of stuff. Right, so that's what we were running all the way up until 2010. We were entirely still based on this. So we'd computerized a lot of other stuff, but this was sort of the last frontier because it was so difficult to do. And we had problems. Of course, this piece of paper has a lot of problems. I mean, first of all, it's illegible. It doesn't help you at all with anything like scheduling when the drugs are being given. It doesn't help you at all with how the drugs are actually given to the patient. It really doesn't help you. You have to trace anything back. You have to actually scan through tons of paper to find anything. So it's actually a really horrible situation, but it was better than anything else we had. It was the only way this could work. And so we thought, okay, we're now ready to computerize this stuff. How do we do it? And so you can't just do this part way. This is one of the most disruptive things we actually have done, because you have to entirely automate the whole process end to end. You can't just do a bit of it. So we have the doctors, we have the nurses, we have the pharmacy, and we have all this tech in the middle. It's not particularly high tech, I have to say. It's just good use of technology in a very process-oriented way. And it's another one of these long projects that we do. Everything we do is a long project. So we started in 2010. It's not going to finish until 2021. And that's a bit extended because of the Kwong Wah Hospital redevelopment. But 2017, so it's essentially at least a 7-year project to get all the major hospitals in Hong Kong. Well, it's 2018 now, so it's basically done. We've finished this project now to get all the major hospitals in Hong Kong on this new system. Why is it so complicated? Well, we're not just going to automate the process. We have to improve it. to make a change like this, such a huge change, you have to make big improvements. So we're looking at all the safety and all the efficiency things that a new system like this could provide, and we had to implement all of them, and they all had to be flawless from day one, right? So I'm not going to go through these, but there's a whole list of stuff that we wanted to improve that a paper system couldn't deliver. That was for doctors prescribing, this is for nurses administering, and this is, oh, okay. And there's also massive workflow changes. So there's all these things that used to be done, now can all be done by the system. So it's a massive improvement. But you had to it all had to be in place from day one. Nurses, lots of improvement. And pharmacy, lots of improvement. So we developed the system in-house, rolled it out, took a while. And then we had to, of course, we have to measure how it goes. And I'm glad to say that it actually has done what we thought it would. It's improved the rate of errors happening. People like it. It's not too burdensome. It enhances the efficiency of staff. And also, it saved 168 trees per hospital per year. Just less of those printouts. So it's all good. So that was a success, but it was a high-risk venture. Here's another one, community call center, which is a slightly different type of thing. But what this is a call center full of sort of part-time or retired nurses who aren't actually looking at patients, they're calling the patients. So it's a new service model for us. And what this came from, it came from a data project actually, where, oh dear, okay, there's a PowerPoint conversion problem. Never mind. So what we did was we took all the data from 1 year of hospital admissions and looked at all the patients who were discharged for that year, looked at their data. Now this was not a sort of machine learning type. This was in 2006 or 7. We didn't have those techniques then. This was just normal regression analysis. But we managed to find a formula which would predict which patients would be at risk of problems after they were discharged. And then we said, okay, if you're at risk upon discharge, we will give you a phone call. And that's all it was. And that phone call managed to get a reduction of 25% of post-admission problems just from a phone call based on the data. So this was, to us, maybe our first big data project. But it was more traditional type of data project, but still a data project. But the success of this led us to expand it out to other types of patients. So we're looking at chronic disease management like diabetes. And here we're able to see that the call center, backed by the sort of data analysis that we're doing, allows us to improve the behaviors of diabetic patients and also improve their control. So this is healthcare, right? So we're talking about an improvement of 0.23% HbA1c. That is actually massively significant. It looks tiny, but in healthcare, these sorts of incremental gains are really big. So again, a low-cost intervention backed by data allowed us to make these sorts of improvements. And then because of that, we kept on going, and we said, okay, we're going to enhance the model some more. And now we've developed a whole thing called integrated care model with dedicated nurses looking at specific types of patients, improving the whole discharge planning, and then linking it with all sorts of other services after discharge, and then also linking through to the call center. So what we're able to do is we're able to make the innovation and then keep it going and add new layers to it over time. And then these things become just part of the fabric of Hong Kong healthcare. Right, this slide is just to show you. Now, I'm not going to claim all the benefit on this slide is due to the electronic system, but you look at the world. These are OECD countries. Their expenditure on healthcare and it's been growing over the years. This is one of the things that the U.S. especially has to grapple with is if you keep on going, you end up your entire economy is healthcare, and that's clearly not possible. But what Hong Kong's been able to keep way down here, at way lower than all of these other countries. There's other reasons. We're more compact and stuff. But I'd like to think that a lot of it's due to the sheer efficiency of the work we do in the hospital authority, able to provide the majority of care in Hong Kong with very low staffing levels, basically. And it's only possible because of the systems that we have. Right. But we can't rest on our laurels. Change is the one constant. We have massive change in medicine ongoing, especially, there's a lot of talk about the genomic medicine type of stuff. We have massive change in technology, and we have massive change in the way people themselves act. I mean, this is your typical MTR, right? Everybody's on their phone. And this behavior did not exist 5 years ago, right? Now everybody's doing this. So everything's changing, so we have to change accordingly. And the other thing, of course, is there is disruption coming. The new technologies that are coming on, they're just so all-encompassing and so change-inducing that we have to be on board with these. And the ones that we are dealing with particularly will be mobile, cloud, Internet of Things, big data, machine learning. And these are where we're starting to look at in a much more sort of startup fashion, even as an organization like us. In fact, I talk to a lot of enterprise level IT people, CIOs of Fortune 500, that sort of thing. And everybody has got an innovation agenda. You have to now. Nobody can sort of hide from this stuff. And one of the issues there is because we're talking about ecosystems now, not just how well can I do stuff, it's how well can I interact with the ecosystem, which includes the startup ecosystem. And we're dealing with the EHR and all sorts of other things as well. So we're much more engaged now with the rest of the ecosystem. In fact, in the past, I wouldn't have spoken at this sort of conference anyway, but now I will. All right, so for us, actually, as an organization like the HA, this is a big deal, actually, because we are what we call mode 1, high reliability, very well planned, long-term project type of people. That's how you do IT of our scale. But mode 2 is how you do innovation. So we've had to learn a lot more mode 2 stuff. How do I get approval, through our organization? It's a new thing for these sorts of, the speed that we have to work at. Now, we still do the long-term stuff. We have a 5-year strategy, but embedded in our 5-year strategy, now here's the 5 portfolios of our 5-year strategy. This is the CMS that I'm talking about. This is generation 4, and that's that big, long project continuing to go. But we have in strategy 2, we call it enhanced patient experience and outcomes, and that's where we put all the new stuff, all the innovations, the new tech. And that is a much faster sort of cycle. We have the similar sort of thing for our own staff, digital workplace. And the other thing we have to do is we have to look at the whole IT infrastructure. So we're doing a lot of work at bringing in new types of technology, especially internet scale technologies, platform as a service, all this sort of stuff. And we're doing that there, and our own staff, how do we get them up to speed on this stuff? So we're doing a lot of work there. I'm not going to be able to talk about this is the CMS 4 sort of picture. We call it the 5 Ps: protocol-enabled, paperless, closed-loop, patient-centered, and personalized. I won't have time. This is like an hour-long talk, but this is what we're doing. So you'll see the fruits of this in a while. But in the more of the patient experience side, never mind. Okay. We're doing a lot of work on the app front in terms of mobility. Now we're moving the entire CMS, all the bits that make sense, onto an iPad, so that doctors now can take the iPad and go around and do their thing next to the patient rather than having to go back to the computer. So that's the mobile clinical suite, and that's been an ongoing piece of work. And we just announced we're basically in Hong Kong, in the hospital authority, every doctor is going to have an iPad which they walk around with as they do their ward rounds. But we also have a lot of apps for the public, for patients, and for our own staff. These have been released over the last couple of years, and some of you may have downloaded them. Please do if you haven't. It's early days. What we will be doing is we're going to, we started building lots of apps. We're going to consolidate them back, and that'll be stuff we're talking about in the coming years. I just want to point out one of them. This is called the Mobile Staff Health Record. This is actually an internal app at the moment for our own staff. But you see here that we've got appointments, we've got radiology, we've got medications, we've got laboratory results. So we're starting to share out your patient's own personal record back to the patient themselves rather than just to the doctors and nurses. This is early. This is only for staff at the moment, but it's going to come. It's going to come. Now, big data. This is one of the most exciting areas. Now, Dr. Cheung mentioned that this is in the policy address last year. The hospital authority will establish a big data analytics platform. I'm just going to mention this a little bit. We will establish this year, right? 2018, we just started, so not done yet. But we will do this this coming year. And the idea is that we're going to take the HA data. Now, HA data is highly sensitive. It's everybody's personal medical records. So we have to be very careful with how we allow people access to that. But what we're doing is we're building what we call the data collaboration laboratory within the HA, and we're going to put the HA data into that. We're going to have to do a lot of work to anonymize it, scrub it clean of personal data. But even if you scrub data clean, when you get to the scale we're talking about, you can still find people. So starting off, what we're doing is we're setting up a platform which is a machine learning environment, GPUs and the software stack and all that. and have collaborators working with us to use the data to develop, use machine learning techniques and develop algorithms to, predictive analytics or whatever it is that we want to do using those tools and that data set. Now, initially, it's going to be very collaborative because the data itself it's operational data. This is not scrubbed, clean research data. So therefore, there's a lot of stuff there that you have to understand before you can actually use it properly. We're well aware that training machines on bad data gives you bad algorithms, right? So we have to understand what we're doing. So we're starting off with a collaborative approach. We're going to mean working with the academic sector first this coming year and start some projects using this platform. So this is the HA Data Collaboration Laboratory. Start this year. Over the years, it'll expand. So we'll see how it goes. But this is we're starting off here. All right. We've done some internal work on stuff like, you will have probably heard about radiology. Image analysis is very advanced nowadays, and radiology applications being more accurate than actual radiologists, that sort of thing. And we're actually finding that we can replicate a lot of that stuff in-house as well. We have lots of images after all. And so it's interesting to see how that's going to go. Now, the EHR is something that I want to just quickly mention. This is the big government project linking all the various healthcare sectors apart from the HA together. And it's actually, the intent is this is an ecosystem. It's not an IT project, it's actually a healthcare project trying to allow different models of healthcare, more integration between sectors and all that sort of stuff, specific programs. And there's also a patient portal, which we're also starting to develop on the EHR. So this will be, again, on your cell phone, access to your own data and services through the EHR. So I started with telling you about the the steps of electronic medical records, e-health in the hospital authority. Build the record, support the processes, improve the quality. Okay, so that's how we've been doing things for the last 20 odd years. I think where we're going to now is we have a fourth level. We want to enable new models of care, like a call center, getting away from just the traditional service models, make the data much more involved, much more actionable, and get patients engaged in their own care. So that's where we hope we're going to go with the technology. And maybe some of the stuff that you guys are doing can fit in with the processes that we're talking about, and that would be great. Okay, thank you for your time.
Wow. I will take that. Dr. Cheung, thank you so much for coming here. Ladies and gentlemen, he just gave you the keys, the magic keys to the kingdom. All right, those are the pain points. This is what people like Dr. Cheung are dealing with. Thank you so much. Really impressed you came down here and gave us the inside track. Ladies and gentlemen, one more time, Dr. Cheung.